Lid sign mimicking Myasthenia gravis, a clinical pearl. The objective is to report a child who presented with ophthalmoplegia and Cogan sign mimicking Myasthenia gravis. Moving on to the case history, 6-year-old female child came with the complaints of drooping of the lids for the past 10 days. There was history of double vision, history of imbalance while walking for the past 13 days, history of one episode of vomiting. There was no history of fever or any bladder bowel disturbances. Birth history was unremarkable. On clinical examination, child was conscious and oriented. She had a wide-based gait with absent plantar and knee reflex. Ophthalmic examination showed that the child was fixing and following light in both the eyes. Hirschberg test was orthophoric. Color vision was intact. Slit lamp and fundus examination was normal. Extraocular motility showed there was limitation in the dextraversion, supraversion, levoversion, and infraversion. On asking the child to look down and then to look straight, she had a classical upper lid twitch suggestive of Cogan's lid sign. So, is this Myasthenia gravis? What next? How are we going to manage? Going back to our history and examination findings, the sudden onset of the problems and the presence of gait abnormalities and areflexia prompted us to think of Guillain-Barré syndrome, probably a Miller-Fisher variant. She underwent various tests. CSF analysis was normal, neuroimaging was normal, acetylcholine receptor antibody was negative, anti-GQ1 antibody was positive. Diagnosis of Guillain-Barré syndrome over Myasthenia gravis was explained by the rapid onset, presence of ophthalmoplegia, ataxia, areflexia, and a positive anti-GQ1 antibody. She was treated with systemic steroids and she had a recovery in the gait and ophthalmoplegia over a period of 1 month. So, here are our points for discussion. Cogan lid sign is elicited by asking the patient to look down for 10 to 15 seconds and then to look straight, during which there is a twitch in the upper eyelid. The exact pathophysiology is unclear. However, the twitch is proposed to be secondary to initial fatigability followed by recovery of levator muscle. In our case, acute presentation of ophthalmoplegia and ptosis with the presence of peripheral weakness and areflexia, one needs to rule out emergency conditions like Guillain-Barré syndrome, though the patient had Cogan's lid sign. Serological testing was positive for anti-GQ1 antibody. Post-treatment, she had good recovery. To conclude, it's important to understand that Cogan's lid sign is not pathognomonic for Myasthenia gravis. It can be seen in conditions like Miller-Fisher variant of Guillain-Barré syndrome. Thank you.